Good morning to everybody. As you can see, you should be able to see on the screen, title of the webinar this morning is an introduction to public health. Having looked at the people in the meeting, I know there's quite a wide range of current understanding, current experience in public health, but this session is really pitched as an introduction to what public health is, what it does, and how it works. So if we start off with a question that will be familiar, and a lot of you will be familiar with this definition from 1948, but still very much still very commonly used. And so what is health? Health is a state of complete physical, mental, and social well-being. And the social well-being does often get forgotten, but it is about the whole total well-being. And it's not merely the absence of disease or infirmity. So it's not just about not being ill. It's about having a positive well-being, both physical, mental, and social well-being. So it's much wider than just the absence of disease. And if we look at, okay, what is public health, then health or healthcare, and you'll often hear, certainly in media, or people will talk about health, what they actually mean is illness. But if you're talking about healthcare, it's usually the treatment of individuals. So if you go to see your GP, if you go into hospital for treatment, if you have an accident and go to accident and emergency, if you go and see a physiotherapist or another allied health professional, it's very much about the treatment of the individual, clinical care for illness or injury, and it's about improving health and mitigating the health risks. So it does include health promotion, but very much health promotion for the individual, what that individual needs to do to improve and maintain their health. Whereas if you look at public health, the big difference, what makes it public health is that it's concerned with the health and well-being of a group of people, a population, and that word will keep on cropping up, a population. It's about improving the health of that population and the prevention and mitigation of risk to health well-being at a population level, and that is substantially different from treating the individual's health and well-being. So you're looking at a population average, you're looking at population health. That population can be local, it can be a small geographical community or small community. It can be defined by ethnicity, it can be defined by faith group, it can be defined by people who like going snowboarding, whatever. It's how you define the population. For most of you working at a local authority level, then the general population you look at will be the resident population for your local authority area, or subsets of that larger population. So it's very much about the health and well-being of a population as opposed to an individual, and what you need to do to improve the health of the population. Doesn't mean you don't think about individuals, and a lot of the work is done with individuals, but it's about looking at the population health. And the Faculty of Public Health, the professional body for public health professionals, it's the science, and very much public health is very much rooted in the science, in evidence, in statistical analysis, epidemiology, demographics. The science is key to what makes public health what it is. The science is what makes public health effective. But the science doesn't work unless you also have the art, how you apply that science to promote and protect health and well-being, how you prevent ill health and prolong life. So it's about how do you do that. So if you may well know, the evidence suggests we should take these steps, we should use this intervention. And that's what the science says, but the art will include negotiation, it'll include influence, it'll include working with partners, it will include working with politicians to make sure that the evidence-based intervention is funded and operates effectively. So the science and art promoting, protecting health and well-being, preventing ill health and prolonging life. But then this last bit, through the organised efforts of society. We'll come on later to what determines health, what influences health, but it's public health on its own cannot do much. Public health on its own can inform, it can have the evidence, it can work, but unless it can work with others, it won't deliver an improvement in population health. So it's very much about the organised efforts of society. We'll come on to that. What is the wider public health workforce? Who needs to be involved? Taking a brief history of public health, then, and these are general and they do overlap, and each of them is still just as important as it was at the start. It's just progression in how public health works. So, for the first wave, 19th century, about 1848 Public Health Act, but early mid 19th century, about improving environmental conditions, clean drinking water, sanitation, housing, safer working conditions. Very much part of the changes around the Industrial Revolution, about the urbanization, when you had a big shift of population from rural areas, farming areas into new urban areas. Very rapid house building with very little consideration of sanitation, safety or decent housing. And then so you had the development of the 1848 Public Health Act. Second wave, up to from then round up to sort of the mid 20th century, it was really much more about prevention and treatment of communicable disease. So you had a rapid development of a range of vaccines and antibiotics. Obviously, the first vaccine was much earlier than that, if you go back to smallpox. Third wave, mid 20th century to 1980, and that's when they really started looking at lifestyle factors. How do lifestyle factors affect health? Obesity, exercise, mental health, smoking. So hypertension, diet, exercise. And then the fourth wave, really where we are now, and there's still a lot of work going on, a lot of development work going on that, especially come on to the Marmot review work, the social and economic factors. The impact of social factors, economic factors or socioeconomic factors of the more social determinants of health. What I have got the link at the bottom here, you should have the web page up, and this is on the Health Foundation website, as you can see at the top. But what they've done is they've got, again, they actually go back before that to the 17th century, but they track through all the development of public health across the bottom. It loads. But we won't wait for that. So it goes across the. That one really helps to go through the development of public health and in policy, and it does go right up to the 2000s, 2010s. And so, if that's the history of public health and what public health is, the question then is who does public health? Who's involved in delivering public health? And so, there we are. Who does public health? The public health workforce, who is it? The formal public health workforce, we'll start off with. There are quite different arrangements in the 4 countries of the UK. So Public Health has Public Health Wales, which remained part of the NHS and has people working at a local authority level. And you've got Public Health, you've got NHS Scotland there, and Scotland are developing Public Health Scotland. and Northern Ireland are different yet again, so it's different in different parts of the UK. For the purposes of today, I will focus on the English model. So in England, since 2013, public health moved out of the NHS, where it moved into in 1974, but public health moved out of the NHS back into local, or the majority of public health functions back into local government. You had the formation of Public Health England, which is a national public health body. You also got the National Health Service plus others involved around that area. So if you're looking at the formal identified public health workforce, the two main parts are public health in the local authorities and public health in Public Health England. Public health in local authorities has changed dramatically since it moved over in 2013. And there are many different models of public health delivery now at local level. Some areas have still kept a designated public health department with a core public health team. Some have disseminated public health much more widely across the council. And so it's very different models of how public health is delivered at a local area. And there are good examples of successful public health being successful public health within each of those models. All the different models can work, but what happens politically at a local level. Local authority public health has a series of mandated functions from the 2013 move, from the Health and Social Care Act 2012, but as an overarching view, helping people make healthy choices, so the lifestyle. Smoking cessation, healthy diet, physical activity, public mental health. They have an early years responsibility, so local authority public health is responsible for commissioning health visiting and school nursing services, the delivery of the National Child Measurement Programme, which measures and weighs most children, should be all children, at reception year and year 6 to monitor child obesity. Sexual health and substance misuse services, though not abortion services, they stayed in the NHS. Addressing the wider influences of health, so education, employment, active travel, fuel poverty, healthy urban planning, and a whole range of other bits linked to social care, children's services. Local authority public health also has a responsibility to provide local public health support to the NHS. This has been an area of contention in a lot of areas. In some areas, they've appointed joint public health consultants that operate across the NHS, as in the clinical commissioning group or whatever that's developing into locally, and across public health. Local authority public health also has a role in managing disease outbreaks and emergencies. Very apt just at the moment, very topical at the moment. But that's very much in conjunction with Public Health England. The majority of the resource for outbreak management went to Public Health England, though the responsibility for managing outbreaks stays with the local director of public health. So about disease outbreaks, obviously at the moment we've got you've got COVID-19, but it's also tuberculosis, measles, norovirus and rotavirus, the winter vomiting bugs, often in schools, and in residential and care homes. So there's a whole range of other outbreaks that are constantly ongoing beyond the current pandemic. And another big part of the role of public health at a local level is that influence. It's the art of public health. It's using the science and then the art of public health, negotiation, influencing, trying to build public health into all policies. I mean, healthy urban planning, there's a lot of work going on at the moment around healthy urban planning, health impact assessment, trying to look at how you can use the design of the urban environment to either promote active travel or to help try and improve health around, and especially mental health. England's role, any of you who are working in local authority public health or Public Health England will be aware that there was a big change when public health moved, in that the Public Health England now has a very limited role has a very limited role in telling local in managing local public health delivery. It's much more about coordination, about collecting data. So advising government, protecting the nation from public health hazards, preparing for and responding to public health emergencies. Again, there's the obvious pandemic at the moment. Looking horizon scanning to see what's coming over the horizon, to see what the future challenges might be. Supporting local authorities around immunisation and screening, supporting the development of the public health system and its specialist workforce. So working with public health training, working with the Faculty of Public Health to try and do that. And researching, collecting and analysing data to improve the understanding. And certainly on a day-to-day basis, when I was working in local authority public health, this last one was one of my main areas where I worked with Public Health England, using their public health data ones. And I've just seen on the chat, somebody's made a very good point. If we go back to local authority public health and managing the disease outbreaks and emergencies, then one of the key groups with that, if you're looking at all the discussion around contact tracing now, one of the key groups, one of the key professions who do contact tracing as part of their daily job and who have a lot of the expertise and infrastructure and are the environmental health departments in local government. And they are an essential part. And certainly in a lot of areas, environmental health and public health have very much joined forces and been integrated into joint teams in local authorities. Just some of the organisations there, that you can go a lot wider than that. You've got National Institute for Care and Health Excellence, Faculty of Public Health, Local Government Association, obviously very important, Care Quality Commission, NHS, different bits of the NHS, Royal Society for Public Health, and there's a whole range of other groups, other logos and groups you could put in there. There's a very wide range of professional bodies involved or who can influence public health. And then the Royal Society for Public Health, which I mentioned, worked with the Centre for Workforce Intelligence. This is from a few years ago, but still valid. And they started to try and map, so okay, who else out there has can have an impact, can influence public health, can influence the health of the public. And you've got here admin and management, education, protection services, so fire, prison, police, science and engineering, transport, arts and media, sport and fitness, retail. So there's a much wider range of people who have a potential impact on public health, though they are not actually public health workers. But it's people that need to be worked with, that public health needs to work with to understand, to try and maximise the impact on improving the health of a local or wider population. They came up with an estimate of around 15 million workers could potentially have an impact on health and well-being. And if you look at very much at what's in the news at the moment, with face masks in shops, retail workers have a significantly higher rate of infection and deaths from COVID-19 than a lot of other sections of the population. Other groups that are hit particularly hard are bus drivers, train staff, people who have have day-to-day contact with an awful lot of different people. So the use of masks, they have a role in promoting the use of masks in those environments, but also the use of masks really helps protect these vulnerable workers from getting infected. And as part of developing the wider public health workforce, as part of developing the formal public health workforce, the UK Public Health Register have developed a practitioner registration. As it says here, it's formal registration with the UK Public Health Register as a public health practitioner. The UK PHR also have a professional registration for non-medical public health professionals at the public health consultant level, the specialist registration level. But say they also run a practitioner scheme, and where you can complete a portfolio showing you have knowledge, understanding, and you've applied a range of different public health competencies in practice. It's assessed, moderated, and verified through a regional scheme. And in the West Midlands, it's Sally James Health Education England, but there's more detail in the bottom. And certainly more, it has been written into the job descriptions of a number of local authorities that people working at a certain level will need to be working to or to have public health practitioner registration. There's more detail at the bottom. You may, in some, I'm presuming some of you may already be on the scheme, already be public health practitioners. But if you're working in public health, then this is certainly worth following. And when I do training on this or assessing for this, then increasingly you're seeing people from outside the NHS, outside local government. In some areas of the country, you're seeing more people from the private sector, for instance, Virgin Care, where they're working in conjunction with local government or the NHS. And you're starting to see people from wider areas working towards this registration. So there's more information at the bottom if you want to follow up on that. Okay, so that's what public health is. It's a definition of public health about physical, mental, and social well-being, working using the science and the art of public health and the organised efforts of society, and then looking at how wide that goes. Potentially 15 million people who can have an impact on public health, though obviously they may not recognise that as part of their role, even though they're delivering it. So that's what public health is. That's the public health formal workforce and wider workforce. If we now look at what makes public health, what are the sections of public health? Generally, we separate it into three domains, three areas of public health. Again, these aren't fixed, and people tend to work across more than one, but you'll have a focus. Public health work will be focused in one of these areas. Just a quick one here: health improvement, healthcare, public health, and health protection. Health improvement largely sits in local authorities. Health protection, Public Health England leads, but has to have a big local authority input, especially around immunisation, vaccination, screening, whatever. And then healthcare, public health. So healthcare, public health is about ensuring that healthcare, so that care of the individual, that treatment, is based on the best available of evidence. So it's about understanding the current problem and what's the current situation, so the needs assessment. And one of the key competencies, one of the key skills for public health is needs assessment, health needs assessment, healthcare needs assessment, health impact assessment. Research into new and existing treatments and interventions, evaluating treatments, interventions and services, and making the best use of available resources. There's never going to be enough resources, and it's about how do you spend what you've got in the best way to improve population health. How do you make the most of what limited resources you've got? So it could be developing a new service of people with heart disease. Now, you've got to understand who has heart disease in the population. How's it changing? Which bits of, if you're looking at a local authority area, which bits of the local authority have higher levels? Which members of the community, members of the population have higher levels? And again, that may be broken down by age, sex, ethnicity, geography. What's the current best evidence for treatment? How can you improve heart disease? How can you stop people getting heart disease? What's already in place? What services are already there? You're never working from a blank canvas. You're always building. You're always having to build on what's already in place. And a lot of the time, that can be a positive that you can develop what's already working, or review, stop something and commission something else. And if you're looking at what's already in place, going beyond just health services, looking at what's out there in the community, looking at what the wider councils are already doing, looking at voluntary sector charities, what are they doing to support people in the community? Looking at people like the British Heart Foundation and other works. It's about looking at the assets you already have in place to try and help you work on this issue. And again, the big question: how will we get the best outcomes within the available resources? It's about how do we get the biggest bang for our buck? That's developing a new service, and evaluating an existing service. And certainly, again, working in local authority public health, you had requests from different bits of the council, different sections of the council and different partners to help with planning or undertaking an evaluation of a particular service. How do you, what outcome measures do you use? What output measures? How do you evaluate it? Is it evidence-based? Is it working? Who's it reaching? But more importantly, who isn't it reaching? Who in the population, your target population, is not receiving the service you should do? Is it value for money? And certainly going back to the who isn't it reaching, one of the key bits there is working with the local community, understanding your population, doing a population needs assessment to understand who out there has got heart disease and who isn't getting the treatment. If you looking at who's turning up to services and comparing that with the expected disease prevalence, expected amount of disease within the population, to try and work out who you aren't reaching and where you need to go differently. Okay, moving on, health protection. Obviously very topical at the moment with the pandemic, but ensuring the safety and quality of food, water, air in the general environment. And again, going back to the previous point, that is very much wider council, but it's environmental health area of expertise. It's very much, again, managing outbreaks. Another instance. Some of the most common outbreaks will be food poisoning related to an event, related to a particular food outlet. And again, environmental health, working with public health and environmental health, has a wide range of expertise and experience in doing that. And also preventing the transmission of communicable diseases. At the moment, yes, but there's certainly things like winter vomiting bugs, things like Legionnaire's disease, things like tuberculosis. Measles is a big one at the moment because we have had some outbreaks of measles. So it's preventing the transmission of communicable diseases. Just as some headline figures, it's estimated that about 2.4 million cases of foodborne illness in the UK each year. And that's estimated because most cases of foodborne illness will not be reported. If you've been to and had a bit of a dodgy meal, or you've eaten something that wasn't quite right, and you've got mild food poisoning, it won't get reported. You may have a couple of days off work, but it won't get reported to the GP. It won't get reported to the NHS. So it very much has to be an estimate for foodborne illness. This one, air pollution, is estimated to be a contributing factor in between 28 and 36,000 deaths a year in the UK. So between 28 and 36,000 people in the UK die, and their death is in some way attributable to air pollution. And that's air pollution as in the gases, the nitrous oxide, sulfur compounds, but increasingly we're realizing the importance of very small particles of pollution, what are called PM. So there's PM 2.5, which is particles of pollution below 2.5 microns or 5 microns, PM5s. But it's increasingly realizing the importance of those small particles. And there's new research coming out all the time, and it's certainly been shown to be associated with say causing, but associated with reduced cognitive development in children, kidney disease, possibly dementia, certainly linked to increases in heart disease and strokes in cardiovascular disease. There's some new evidence just starting to come out now around links to possibly to eye disease. So air pollution doesn't only affect the lungs, it affects all systems within the body. So there's new research coming out all the time. And certainly there's a lot of reports in the media and some papers have come out just recently showing that air pollution seems to be associated with worse outcomes around COVID-19 infections. Part of the problem with that is generally areas with high air pollution tend to be areas with higher deprivation, and that can act as a confounder. It can actually influence the effects, but it certainly looks like increased air pollution is linked with worse outcomes around COVID-19. So that's air pollution. And there are certain diseases, again, measles, tuberculosis, that are notifiable. The doctor, often the GP or the hospital doctor, has a legal responsibility to report that case of illness through a formal process. And that came up with around 70,000 cases of notifiable diseases in England and Wales in 2018. Again, there's links to there's links to all these reports if you want to look into them further. So that's just the scale of the disease, the scale of the problem you're looking at if you're looking at health protection. And the role of public health, this is local authority and Public Health England, is about identifying potential risks. So yes, there were pandemic flu plans in place, but there's also plans, for instance, what happens if there's a chemical lorry accident and spill on the M6 overpass at the north of Sandwell or Wolverhampton or around that area. It's all about surveillance to identify disease outbreaks or incidents. So if there's more than one case of a disease, and again, public health locally will have an impact role in that, environmental health definitely, and public health at a regional level as well. Screening programs. So the NHS delivers a lot of the screening programs, but they will identify increasing numbers of a particular cancer, increasing numbers of a particular disease. Immunisation and vaccination programs. One of the biggest public health wins we've had over the last 100 years or so. Emergency planning to be ready for when it goes wrong. What could possibly go wrong and what do we need to have in place to deal with it? If you're doing all that, then the main thing is you have to coordinate that across a very wide range of partners. And if you're looking at emergency planning, you've got all the bits of the local authority, including adult social care, children's services, public health, transport. You've got all the parts of environmental health, obviously all the parts of public health. But then you've also got to involve the police, the fire service. You've got to involve possibly community groups for certain outbreaks. And obviously, across all of that, you need to keep the politicians informed and give the politicians the information and evidence they need to make the policy decisions. An incident or disease outbreak, there's outbreak management. There's a formal process, a formal structures in place to handle any particular outbreak, either incident or disease outbreak. Case identification for finding out who's got the disease. Contact tracing and containment, very topical at the moment, and a lot of question about how that's being managed nationally, when locally there are robust systems in place of managing that. And obviously linked to all that, media, communication and public awareness. So the role of public health and health protection is very wide ranging, and it's about predicting what might happen, being ready for when it does, and then reacting when it does, and then managing afterwards. Okay, so we will come on to the coronavirus, COVID-19, a bit later on when we look at data. But Coronaviruses are a family of viruses, including a number that actually cause the common cold. So most of us at some point in our lives will have had a coronavirus, as in the common cold. This particular one, the virus, is SARS-CoV-2. So the virus SARS-CoV-2 causes the disease COVID-19. And it's the severe acute respiratory syndrome coronavirus 2, linked to the SARS outbreak that happened a few years ago. But SARS had a much lower transmission rate, so it didn't maintain as an epidemic. It was controlled. The important point is that SARS-CoV-2 is a novel virus. It's a new infection in humans. The best evidence is it mutated in an animal into a form that can transmit between humans. But we don't have any innate immunity. We don't have any innate immunity to that particular virus. It seemed to start in December 2019 in Wuhan in China. And because we don't have any innate immunity, it can affect every system in the body. So you're starting to get a lot more cases reported now, a lot more reports of longer-term damage, longer-term illness following on from COVID-19 infection, sometimes from relatively mild COVID-19 cases have long-term physical effects such as tiredness, mind fog as they describe it, or longer-term lung damage for still developing over time now. So that's coronavirus, as it's called, is SARS-CoV-2 that causes the disease COVID-19. So we'll come on to some of the data around that later on. So that's healthcare, public health, health protection, and now health improvement. And as I say, most of health improvement, the delivery of health improvement, sits at a local authority level. So improving health and well-being, reducing health inequalities, tackling the factors that influence population health, and the last section of this morning is very much about that. Helping people make healthy choices, which has been the focus of public health policy certainly since the late 80s, early 90s. Across a whole range of governments, the focus has been on 5 a day, getting individual choices. The difficulty, those individual choices are very much constrained by the external factors and external environment. And again, we'll discuss that more later, but about the wider the social determinants of health. So that's health improvement. We'll cover a lot more on that later. Okay, very aware that these webinars are quite difficult to focus on. You need a break. So we'll have a 5-minute question time now if there's any questions people have put in the chat. And then we'll have a few minutes break before we start off on the next section. Looking through the chat, can a population be defined as a workplace? Very much, Natalie Barrow, is that very much workplace health is a very important area of health because people spend a lot of time in the workplace, and the workplace has a potential of having a big impact on health, whether that be physical health due to the conditions of working, noise, air quality, physical activity, but through mental health, through having the right workplace for computer stations. There's a whole range of, yes, workplace health is very important, and you can certainly define a particular workplace as a population, as a target population. Okay, if we go back to the slides. Right, so next section, how do we know things in public health, and what do we want to know? What do we need to know? And for me, it comes down to 3 simple questions. Sitting underneath this is a lot of complexity. But for me, the key part of public health is to try and understand exactly what you're trying to do, try to understand it in the simplest terms. I think it was a Feynman, was a physicist, who said something along the lines that if you can't explain it clearly, then to someone who doesn't understand, then you don't understand it yourself. Or as John Middleton, my ex-boss, used to say, is you whatever it is, you must be able to explain it to the man down the pub. And so 3 simple questions: what's happening? Why is it happening? And most importantly, what can we do about it? And that we in the widest context, what can we do about it? We need to be able to assess population need, understand the problem, but as I say, what's already in place, it's not only looking at the deficits of what the problem is, what assets are already out there we can work with and build on. This needs to inform the commissioning of new services and interventions, the development of new policies, development of partnership working with other partners, with the voluntary sector, with communities. Evaluation of services and interventions, and any evaluation needs to be built in as part of the initial planning of any project or any intervention, and needs to be appropriately resourced so it can be effective. Epidemiology, which we'll come on to, obviously very relevant, but epidemiology, understanding disease and disease patterns and health patterns, and research. So what do we need to know is, again, what's happening, why is it happening, what can we do about it? A good way of looking at it, and this slide was borrowed from Ralph Smith, who I did work with in Sandwell, is now working elsewhere. So you start off at the bottom, data. A raw form of data, just numbers, databases. You get that from many different sources. And you need to understand it. You need to clean it so it's actually accurate. You need to process it to make it useful. So just numbers and data, which is there's an awful lot of it out there, and is very expensive and very difficult to manage. You need to turn that data into information, turning raw numbers into graphs, charts, tables, but not necessarily with any narrative or interpretation, but they start to give you an idea of what the problem is, how it's changing, who's affected. You then take that information and do some more analysis around what's going on, why. Interpretation of assessment provides intelligence on trends, needs, review of evidence, so turning data into information into intelligence. And then using that intelligence to inform decisions. And certainly for anything larger scale, that will be a political decision. It will be a decision by the politicians. And they have to weigh all the data, information, but specifically the intelligence, have to weigh the intelligence against other considerations around finances, around, okay, if we spend the money here, what aren't we spending, and opportunity costs. If you spend the money on one thing, what isn't being funded? So balancing costs, balancing spend across a whole range of different priorities. So it's about the decisions are about how using the intelligence to make the decision about where you spend your money, where you invest your resources, not only money, but people, time, expertise. So it's about taking that raw data and processing information, which is just graphs and charts, intelligence, where you start to look at what they actually mean locally, and then using that to inform decisions. If you want to look at examples of certainly the intelligence, then a lot of the joint strategic needs assessments done at local level, so public health at local level, working with a whole range of other partners, will produce joint strategic needs assessments that analyse the intelligence around the health of the population, what's going on, how it's changing, what needs to be done, what services and assets are already in place. And the key one of those, demographics. As the definition says there, the observed statistical and mathematical study of human populations concerned with the size, distribution and composition of such populations. Understanding who's in your area. If you're looking at local authority, who lives in that local authority area? How many ages, gender, ethnicity, location, who lives in that area, and how's that changing over time? It's never a fixed point. Populations are changing all the time, people moving in, people moving out. So it's constant change, but it's what's your best evidence at the moment? What's your best measurement at the moment of who's living there? So you've got age, sex, ethnicity, religion, and a whole range of other considerations. And the Office for National Statistics, obviously you have the census, so we'll have one next year. I haven't heard whether that's going to be affected yet, but there should be one next year. And then they produce mid-year estimates in between to look at populations. So the first step is understand. If you're looking at a population, is understanding who is that population, who make up that population, what do they look like, how old are they, what gender. So it's about understanding all that picture. And just as an example, there's a couple here, local ones. Population pyramids. So you've got male for Birmingham, we've got male on the left hand side here, female on the right, and at each age range you've got the proportion, you've got the percent of the total population at each of the age ranges. The pink and blue straight lines are the national average. So what you can see for Birmingham is the sort of 20 to mid-30 age range, there's a larger population than the national average. If you look over at the Solihull one, generally, you've got the same sort of pattern. However, if you look at the older population in Birmingham, it's both on male and female. It's less than the national average at the older population, whereas Solihull is actually more than the national average. So if you're using this information to look at trying to do longer term planning about what services the council is going to need to provide, then in Birmingham, you need to take account of this group coming through here. Whereas in Solihull, you need to recognise you've got an older population, so you may need a different balance of services. So even just and you can look in further into this, you can do more analysis about this. But even just as a simple demographic depiction here as a population pyramid, you can start to spot differences between populations. You can start to think through what might that mean for longer term planning? What might that mean for where we need to invest our resources now, 5 years, 10 years, 15 years into the future? So just even something as simple as a population pyramid starts to give you an idea of how you need to look at services, how you need to look at where you're going to spend your money. And local public health teams and wider council teams, I'm taking in that, are very knowledgeable and skilled about and really have a good understanding of their local area, because they're doing it all day in, day out. They get to understand who's there, what it's like, and beyond just the numbers, they'll have an understanding, working with the wider council, wider community partners. They'll have an understanding of what groups are out there, what are the connections, what networks, what's going on. As I say, the local public health teams will produce joint strategic needs assessments. The annual report of the Director of Public Health can be a very good route, very good thing to look at what are our future priorities, what do we know is going on, what do we know about future challenges, what are our priorities going to be. Every upper tier local authority or unitary local authority has to produce a joint health and wellbeing strategy for the Health and Wellbeing Board. Often those can be quite short and are just really an overarching statement of priorities for all the partners across that area, and that's across the council, commissioners and providers in the NHS, and often the police, the ambulance services, voluntary sector, so a much wider range of partners. Local public health teams also get ad hoc requests for data to support specific projects, to support specific bits of work. And they have access to a wide range of data intelligence from partners. So local public health teams will have access to NHS data, usually. They'll have access to a whole range of data. But beyond that, if you're talking about the analysts at a local authority level, beyond just having access to it, they'll understand it, they'll understand how to analyze it, they'll understand how to interpret that data and information and turn that into actually intelligence to support decision making. Just looking at some of the data available, everything I will show you here is publicly available data. Anybody can access it. So Public Health England, they do local area profiles through their what's called the Public Health Outcomes Framework, the fingertips. And certainly anybody working in public health, especially if you pick up a new area of work or you start working on something new, two areas you will probably go to very early on are NICE, for what's the evidence, but certainly is Public Health Outcomes Framework, the fingertips. It is the envy of an awful lot of countries around the world. The amount of data analysis we can get and it is publicly available is excellent. And it also, as well as going to health, it also includes education, employment, homelessness, drug use, prisons, job seekers allowance. So all that data is pulled together into one place in the fingertips. There's also local health, where you can drill down to a much smaller area. So you can, within a local authority, you can drill down to ward level to really pull off a lot more analysis, a lot more detail, a lot more data, and you can compare between areas, and there's some interactive stuff on there. You can help to compare between areas or to collect data across a number of different areas. You can get a report, a dashboard on a custom area. You can download the spreadsheets or raw data to analyze into information and hopefully into intelligence. There's at the bottom there are good guides that talk you through how to do it. So again, local health is a way about how you can find all this data at a local level, and it goes beyond just the pure public health and health data, as I say, to include everything from employment, educational attainment, unemployment, alcohol use, drug use. There's a whole range of data in there which you can use. Obviously, some of this data is known to be more accurate than others, but they're very careful to be explicit about any limitations to what data you can get access. So that's local health. The NHS has a whole range of data. This is just so as you have the Public Health Outcomes Framework, there's the Adult Social Care Outcomes Framework, and it's got care-related quality of life, proportion of adults with a learning disability in paid employment, social contact, delayed transfers of care. So again, there's a whole range of other data in there that you can pull off for a particular area to really try and understand what's going on, how it differs from other areas, how it's changing over time. So I think if you're anything like me, when it comes to data, you can lose a lot of hours playing around with this stuff. But certainly when I've done joint strategic needs assessments on, I did adult mental health, child and young persons mental health. Before I left the Count Sandwell where I was working, we were working on a joint strategic needs assessment around prevention of violence. And so you're pulling together a whole range of this data from these sources, a whole range of information from partners, be that commissioners or providers, and the voluntary sector and community groups and the private sector where they're delivering services. And you're trying to amalgamate all that into a summary and an overview of where the position now, the future trends, the best evidence, and trying to pull that into a picture that can inform decision making. And that's part of the skills and the art of public health. And as a big part of that, epidemiology. You'll have heard a lot of stuff about epidemiology, especially on social media. There's an awful lot of people who have become, who appear to have become epidemiological experts with a few hours on Google, and a lot of people commenting on it. But there are some really good, if you're looking at social media, there are some really good lists out there of people you can follow who are actual epidemiologists, who are actual public health epidemiologists. I haven't got the links here, but you can find them out there. There are some, if you really want to keep a track of what's going on and what the numbers mean. I'll come on to some other sources you can use in a minute. But epidemiology is the study of the distribution. So how is it distributed? Determinants. So that's what's going on. Determinants, why is it happening? Of health-related states or events, including disease. So it's not only diseases, it's other problems. And certainly there was a panorama one, I think it was on Monday night, about how Scotland used a public health approach for tackling violence. And Glasgow, over 14, 15 years, managed to get a very substantial reduction in levels of community violence. And part of that is using a public health epidemiological approach to understand the patterns of violence, where they happen. In fact, is violence contagious? If you have violence in an area, does that then spread to other areas? And so actually using epidemiology to understanding patterns of violence beyond disease to try and work out what they can do about it. And the West Midlands now has a violence reduction partnership and is doing is doing a lot of work on the similar things in the West Midlands. So it's not just about disease, though that's obviously a lot of the focus at the moment, but it's also about other health-stated events, other things that can affect health. So it's the study of the distribution, what's going on, the determinants, why is it happening, and then the application of this study to the controls. So what can we do about it? Same three questions again. So all health related. There's a link there to that. And the key principles, excuse me. The key principles, time, so when did it happen? Place, where, and is it changing or spreading? And person, who? So time, place, and person. They are the three key questions of any epidemiological work. And distribution, it's the pattern or frequency of health events, again, part by person, place, and time, place, and person. And the determinant is the causes of and risk factors for health events. So it's not only the things that are causing it, it's the things that increase the risk for a particular health or other related event. So epidemiology is a very large, very complex topic, very much based in statistical analysis and mathematical approaches. And certainly if any of you have done or planning on doing a master's in public health, you will be having a lot of statistical analysis and exams on stats. So epidemiology is a very robust mathematical approach to understanding patterns of disease and other events in a population. And if you're looking at how that's applied to COVID-19, locally for the UK, you've got the Public Health England figures, the NHS providers figures, and the Winton Centre for Evidence Communication at Cambridge University with David Spiegelhalter, who's one of our top health statisticians and wider statisticians. So again, there's some sources there for what's going on in the UK. And then there's some really good stuff happening globally, which you can drill down. And I will just share some stuff here. So that one you should be seeing now is the John Hopkins University Coronavirus Resource Centre, again publicly available. And what that gives you, there's a whole range of different information on here. This first page is cumulative confirmed cases in different areas. Don't just look at the dots because it's how it's recorded. America is all red because they report on every state in every small and down to a small area. Canada's just got a few dots because they only report at province level. So you have to understand how it's reporting, and which gives it the pattern it's got. But there's a whole load of information on here. At the bottom here, the bottom of the map, that's cumulative confirmed cases. That's active cases, so the number of active people with active COVID-19 diagnosis at the moment. The incidence rate, how many new cases are coming along. The case fatality, how many of the people who catch it, who are diagnosed with COVID-19, die from it. On this, over on the right here, you've got the global deaths by country. You can look at the number of daily cases globally. So again, there's a whole range of information in there that is epidemiological information that's been analysed, compiled and analysed to try and turn it into information. So they've taken the raw data, they've turned information that gives you a lot of information about what's going on. It doesn't apply that narrative as to why it's going on. It doesn't go on to turn the information really into intelligence, but it can really help support an understanding of what's going on. So I now share something else. This one is the Financial Times, and for this one, the Financial Times has taken off the paywall. So again, this is free to access, and they are producing much more detailed analysis that goes beyond, that starts to go from information towards intelligence, trying to understand why things are happening, trying to understand what's happening. And so, for instance, at the top there, I mean, there's a lot of information you'll need to go through in more detail, but it starts to break it down by each country and how each country is changing. An interesting one they have got here is what they're plotting on this one is, rather than just deaths from COVID-19, they're plotting excess deaths. So the number of deaths above the 5-year average or whatever for this period of the year. So for the last certain number of years, the deaths during this period of the year have averaged a certain number. These charts with these shaded charts above that are the number of excess deaths that have been above the normal expected for this year, and again across the whole, across the world. And then finally, again from the Financial Times, they've got a lot of interactive stuff where you can go and you can put different countries in, you can go for cases, new and cumulative cases. You can, as an interactive chart where you can start to go into a lot more detail, specific breaking down by state in America. So again, there's a lot more analysis there on that chart there. Okay, so it's just start to show how the data is being collated, analysed into information, and then with the Financial Times stuff and some of the other work that's out there, starting to try and turn that into more intelligence to understand why things are happening. Very complex, changing picture. Obviously, there's a lot of stuff going on, but it's just starting to try and understand. So that's epidemiology. So we've looked at what's happening. We've looked at why is it happening. The key thing then is what can we do about it? It's no point knowing what's happening and why is it happening if you're not actually going to change the situation. So evidence, collection and analysis of a wide range of evidence and turning this into intelligence and options to inform decision making. So health evidence, again through public health, through the Public Health England outcomes framework, you can access a lot of the data around hospital admissions for particular diseases, around rates of particular diseases in particular diseases or conditions in different communities. So you can get all the health data. There's all the public health evidence. There's evidence out there around physical activity, around smoking levels, though that's quite not always that easy to analyse accurately. Just as a expanding on that, if you're looking at smoking prevalence, nobody really knows how many people are smoking in a community. If you try and think through where would you get the data on how many people are smoking? And so you've got GP data, but then who doesn't go to the GP, and are people always honest about whether they smoke or not? You've got data for women in pregnancy, because some areas are doing carbon monoxide monitoring, so you can see who's smoking in pregnancy. But for the large chunk of population out there, especially men in their middle age, from 18 up to about 50, who very rarely don't go to the GP, you have very little information. So although there is smoking data out there, there's how many people are smoking in the population, the prevalence of smoking. It's always an estimate, but it's the best evidence we've got, and you'll have to go with the best evidence and the best data you've got. So that's public health. But then there's a whole range of other stuff. There's a whole range of other things that affect health, going back to the workforce and all that wide range of people can affect health. So you need to look at evidence from social care, housing, employment, education. For this one, I'm considering going back to environmental health. Environmental health as part of public health, but beyond that, the NHS, the police, the fire service, and the police certainly have a wide range of evidence, and we were working with them quite closely around the violence prevention needs assessment. But they've got a lot of data they can look at to try and break down and produce information. Communities and individuals, especially including the people who use the services and the people who aren't using the services, the people who could possibly benefit from the service but aren't using it, why not? And businesses, especially if you're looking back to the point about workforce health, you need to understand businesses. What are their priorities? What are they doing? What's their understanding? So if you're looking at evidence for public health, you're pulling in evidence from a very wide range of services, and you have to try and make sense of that. And it'll be different sorts of evidence, different quality of evidence, and you have to balance that and try and triangulate to come up with something meaningful at the end. So if you're looking at where we go for public health evidence, well, NICE publish a lot of healthcare public health evidence around specific treatments for health conditions or illness, for drug use, whatever. But they also publish evidence around public health interventions. So they publish evidence around physical activity. They publish evidence around smoking cessation, around a whole range of public health related interventions. Public Health England produced guidance, and there's work going on at the moment around a guide on health impact assessment in the UK. And Public Health England have produced guidance on a whole range of topics around what can be done at a local area to improve public health. The National Institute for Health Research, they often do very big, large-scale, long-term, sort of 5-6 year research studies around particular topics, such as the location of alcohol outlets and alcohol harm in the population, or the impact of the Decent Homes program from the 1990s on population health. So they do the very large studies. They also produce regular signals where they just highlight specific bits of research or specific bits of evidence. The Cochrane database does global systematic reviews of evidence, plus there's a whole range of other ones that you can use, which are specifically public health evidence. And I say with social determinants, so housing, education, employment, poverty, environment, the police, and a lot of those, there will be some information in the public health outcomes framework and the fingertips. Important thing to remember is that a lot of them come from different sources, and they will have different approaches to evidence, different ways of evidence collection, different understandings of evidence. And one of the ones where that's really become highlighted is if you're looking at the impact of urban design and urban planning on health. Planning is a semi-judicial process through planning committees, and so a lot of their evidence is based around small-scale specific development and housing, whereas public health works on a much larger population level, and there's different understandings of evidence. So it's about trying to work with partners to understand what it means. You've got each of the government departments, so Department for Education, the BEIS, all the different government departments will produce evidence reviews around particular topics and consultations. You've got professional bodies, you've got research groups, you've got the major think tanks and charities, so King's Fund, Joseph Rowntree, Resolution Foundation, Institute for Public Policy Research. There's a whole range of other organisations that are constantly producing evidence around. Joseph Rowntree focuses a lot on poverty and tackling poverty. Resolution Foundation looks a lot at economics and the impact of economics on health. And then the bigger charities, so British Heart Foundation, Mind, Diabetes UK, again, will commission high quality evidence reviews and guidance around particular topics. And then there's a whole range of networks and email updates. So Chime Act for Children's and Mental Health, and I'll come on to another one shortly around a much wider range of public health that goes out weekly. So there's a whole range of sources of evidence out there. And if you're working in public health, and working in a particular area, part of your role, part of the art of public health is to get a good understanding of the sources of evidence of what's going on out there. Social media is a very good tool if you follow the right people. Social media is a very good tool for finding out what's going on, what new research is coming out, what reports are being published, to try and keep on top of this ever-increasing amount of evidence that's being produced. NICE produced some very useful pathways. So this is just a physical activity, and you can click through any of these and it'll take you on to more guidance, or take you on to where you can download the actual guidance, what NICE says about these particular topics. So again, it's a way of navigating through to try and understand it. Working in public health, the same as working in any public sector, and certainly most commercial sectors, you're always very time poor. You haven't got the time to do everything you could do, so you have to find ways of managing your evidence gathering as best as possible to make sure you get everything you need in the easiest possible way. So things like this pathway and some of the email updates are very good ways of trying to keep up to date with what's going on. Just as an example here, very topical today in the news, face masks. Should we use face masks? Should face masks be mandated in different areas? Already in the UK, in England, already mandated on public transport, will be in shops, though for some reason there's a 10-day delay before that comes in. Different patterns in Scotland, Wales, different patterns around the world, and the evidence, and there's a lot of trying to understand the evidence around masks. And if you look at a lot of the discussions around it, you've got the we've got academics, research academics are saying quite rightly, we should look at the best available evidence. The evidence around mask wearing in social settings is very sparse. It hasn't really been done. But so they're saying, well, should we mandate masks with the lack of this evidence? And then you have other groups such as here, Trisha Greenhalgh there on the PMJ one. Trisha Greenhalgh is Professor of Primary Care and Public Health at Oxford University, and her argument here on the right here is that the evidence on face covering, it's not only about the specific trials and observational studies that have been used to look at masks. You need to look at other evidence from basic science. So looking at how droplets spread, looking at how people cough, looking at how aerosols with viruses on spread, epidemiology, mathematical modelling, case studies, natural experiments. So if you have got an area that's used masks, has infections gone down? So it's about not just relying on specific studies on mask wearing in social situations. It's about pulling in all that evidence from a much wider range of areas to try and get the best picture at the moment. We haven't got the time to wait for studies to be done to see if masks work. We have to make a decision now about whether they are likely to help reduce infections and save lives. And so this is the discussion that's going on at the moment around the nature of public health evidence. It's a from a public health point of view, it's an interesting study, but there's a public health principle called the precautionary principle. And the first thing is, if it's not going to do harm and it might do some good, then you need to look at whether that's the right thing to do. So the face mask is a very good example of how public health evidence goes beyond the individual randomized controlled trials and studies, because you need to pull in a much wider range, because the real world is messy. The real world is complex, it's messy. People don't react the same, people don't behave the same. And so you have to take the best estimate you can get, the best guess you can get, pulling in the whole range of evidence. And I mentioned updates. This is just one we produce, goes out from the Learning for Public Health West Midlands Network. Thanks, Joe and Raj, but also the Faculty of Public Health. And it's a weekly email we produce covering, as you say, their sustainability, climate change, active travel, housing and health, air quality, food and food security. And increasingly, there's been stuff going in around poverty, deprivation, the Marmot Review. So it goes out weekly. It's new research and evidence blogs, news, and if you want to subscribe, my email's there. And it's also uploaded to the Learning for Public Health website. Here we are. So this is last week's. So Sustainable Development Goals. You've got everything from coronavirus and the UK Gender Act. You've got the Royal Town Planning Institute. You've got the whole range of different areas, housing, about lockdown and the impact of lockdown on housing and health, climate change and sustainability. So that's just so it's an email that goes out weekly, usually Thursday, sometimes Friday, depending on when it's produced. And so if you want, my email's there if you want to subscribe to that. Okay, so we'll look at now is health inequalities and the determinants of health. What do we mean by health inequality? What does it mean really? It's about what does it mean for the individual, for communities, and what does it mean in what we have to do, how we can work to improve population health. And also as part of that, what influences health and health inequalities, what drives health and health inequality. This is one I find useful. So equality on the left-hand side. Equality means making sure everybody gets the same inputs. Everybody gets the same service. Everybody gets the same inputs. But if you give everybody the same inputs, because their situations are not the same, because some have more advantages than others, the outputs are unequal. They can't all see the match. Although the inputs are equal, the outputs are unequal. Equity is about making sure that the inputs are organized in such a way that the outputs are the same for everybody. So you put more into the people who are more disadvantaged and less into the people who already have the advantages, already have are able to see the match. So that's equity. And justice is about getting rid of the barriers altogether. So you don't need to put the different inputs in. Justice is making sure everybody gets the same outputs, everybody gets the same benefits, whatever. So it's just a way of trying to understand what we mean by equality, equity, and justice. This is the public health approach. Let's get rid of the barriers altogether. Okay, so it's about inputs. It's about what goes in and the benefits or otherwise that people receive. So what does that look like for the British population? This is from, which will come on to the latest Marmot review, which was published in February. Not quite a lot in the chart, but we'll go through it in detail. So the top line, the top grey line there, each of the dots is an electoral ward, or is a neighbourhood area. We're going to say neighbourhood area in England. So each of these dots is, and the solid line is the average line that goes to the middle. And what that shows is on the left here, the most deprived, on the right, the least deprived, and up here, how long you can expect to live on the day you're born. So for the most deprived areas, you're looking 76, 77. When you're born, you can expect to live to about the age of 76, 77. In the least deprived areas, it's just over 80. So the area, the shorter people's lives, the less people live. The bottom line, the green line, similarly neighboured areas, and the solid line is the average. This is disability life expectancy, sometimes called healthy life expectancy, how long you can expect to live in good health. And what you see there is there's quite a gap. So in the most deprived areas, it's just below mid-50s. By the time you get to just below mid-50s, you can expect to have a life-limiting condition or disability of some kind, which leaves you from mid-50s to mid-70s living with some sort of illness or disability. The least deprived, you can expect to live till just over 70 before you get a life-limiting illness or disability, and you die at just over 80. So not only do people in more deprived areas not live as long, the gap here is wider. They spend more of their lives, a bigger proportion of their lives, ill or disabled. And this green line across the middle is the increase in retirement age over the next period. But what you can see is in the most deprived areas, a lot of people, and you have to remember this is population average. So some people in these areas will live a lot longer, healthily for a lot longer, some shorter. On average, they have 20 odd years in illness or disability. And a lot of them are not going to be able to work to retirement age anyway, which obviously has a big impact on them personally, has a big impact on the families, but also has an impact on society, has an economic impact in terms of the benefits and the support they'll need to be able to live without work. So there's a lot of information on that slide. So there was the initial one was published in the first Marmot Review in 2010. This was published earlier this year as an updated one, just to show what the current picture is. Use this working with politicians on a health and wellbeing board as well to put the argument that rather than focusing for the health and wellbeing board, rather than focusing on increasing life expectancy, we needed to focus on increasing healthy or disability-free life expectancy. If you increase that, then life expectancy will go up anyway. But if you focus on that, then that's where the biggest benefit lies for the people in the area, but also it's where the biggest benefit lies for the council, for society. And also linked to that, if you look at it from an economic point of view, if you look at the biggest problem for councils is there ain't no money and there's probably going to be less in future. So the big problem is trying to minimise avoidable expense. And if you look at that gap there, most council costs, certainly for adult social care, housing, whatever, will sit in that gap between when somebody starts to get a life-limiting illness or disability and when they die. So if you can narrow that gap or raise that up, then that will have an economic benefit for the council and obviously for the wider society. What does that mean at a local level? This was some mapping we did back in 2016, but it'll still be similar now. So in Sandwell, life expectancy for men was 2.4 years less than the England average, women 1.7 years. However, if we look at healthy life expectancy, disability-free life expectancy, for men, it's 4 years less than the England average, women 4.6 years. So it actually reverses between men and women between the two. What that means in reality is on average, and I say it's on average, is population. Some people will live longer, some shorter. On average, a woman in Sandwell can expect to live for 23 years of her life with illness or disability. For a man, that's 18 years, but you have to remember that men don't live as long. So if they're living for 70 odd years, then that's a significant proportion of their life they're spending with an illness or disability. And these following charts, you could do this all day with charts of deprivation and disease, but just to highlight some examples. So death from cardiovascular disease by deprivation for all ages in England between 2009 and 2011. More deprived areas, the death rate per 100,000. So you have 208 to whatever deaths per 100,000. In the least deprived areas, 125, 120, 125. So again, you have that slope of inequality. Mental health, adults in the poorest fifth are much more likely to be at risk of or be diagnosed with develop mental illness than those on average incomes. So again, you have that same slope of inequality. And you'll see that same slope across across a lot of illnesses, a lot of especially longer term health conditions, non-communicable diseases. Doesn't hold for everything. It doesn't hold for some cancers because they have different causes. But for most non-communicable diseases, most long-term conditions, that slope of inequality is mirrored across all of them. And just to bring it more up to date, this is from the Office for National Statistics, and it came out in June this year. So again, least deprived on the left, most deprived on the right, so they've actually swapped it round. but it's COVID-19 deaths and excess all deaths in over 1st of March and 31st of May. And again, what you can see is that slope of inequality. The more deprived you are, the higher the death rate from COVID-19 and the higher all other death causes as well. To the point where in the most deprived areas on the right here, most deprived areas, 128.3 deaths per 100,000 in the most deprived and 58.8 deaths per 100,000 in the least deprived. That's going back to the question, that's what's happening. The question then is, why is it happening and what can we do about it? And the why is it happening? From what I've seen, the best evidence at the moment is that if you're living in one of the more deprived areas, you're less likely to be able to work from home. You're more likely to be working in a more dangerous occupations, as I mentioned earlier, such as retail, public transport, driving, whatever. You're more likely to be from a black and minority ethnic community. And we've also seen a lot of data showing that people in those communities have much higher illness and death rates from COVID-19, linked to the same reasons, probably linked to the societal pressures and whatever around what happens about access to work, access to housing, the ability to self-isolate. If you start to develop symptoms, it's far more easily to self-isolate within the home if you've got a couple of spare bedrooms and a couple of bathrooms. Much less likely to be able to do that if you're living in a much smaller house, 2 bedrooms, 1 bathroom. So again, it's not only about the deprivation, it's about the environment and the choices that gives you, and that choices that enables you to have. So again, the same marked slope of inequality from deaths from COVID-19 and from other causes. Again, from the latest Marmot review, life expectancy at birth for males and females between 1981 and 2018. And what you can see here is somebody's got their microphone on. What you can see there is that you have a steady slope going up, and the gap was decreasing between males and females, which is good. However, from 2010 onwards, it started to level off. So that says what's happening. The question is, why is it happening? And there's been a lot of discussion about that. Danny Dorling from Oxford University, Martin McKee from the London School of Hygiene and Tropical Medicine have published a number of reports looking at why we've had this slowdown in the increase in life expectancy. There haven't been any particular heavy flu episodes, especially over that longer period. They couldn't find any easy explanation for why it's happened, other than possibly the impact of reduced spending at local level due to the money available coming into local authorities and into wider public services. It's still a hypothesis. There's no causation being proved yet. It's just trying to understand why we've had that decrease. It hasn't been mirrored in other similar countries. They've continued to increase their life expectancy. So it's not that we've reached the limit of life expectancy. There's something else going on. But beyond that, what they found is if you look at most deprived on the left, least deprived on the right, gain in life expectancy by sex. So for women, in the most deprived areas, they're actually starting to see a reduction in life expectancy. So they're starting to see, on average, their life expectancy decreasing for women in the most deprived areas. And again, that's a very concerning finding. Again, more work is needed to try and understand why that's happening. Professor Sir Michael Marmot said this: since 2010, life expectancy has stalled, which has not happened since at least 1900, and it's a sign that society has stopped improving. There's something happening that has meant that we've stalled on the improvement we've had for over the last 100 years. Looking beyond that, this is from the spirit level. Wilkinson and Pickett are a couple of very well respected epidemiologists, who've been working on this area for many years, looking at the impact of inequality. They published this book. The book is actually a summary of a whole range of research and peer-reviewed papers they published over a number of years. And what they did is they just developed a straight index of health and social problems in affluent countries, which you'll see on the next slides. So it's only in the affluent developed countries, not in the developing countries, because that gives a different picture. And they compared that against average income and against the level of inequality. So for the first one, what this does is the straight index of those problems on the left here: infant mortality, homicides, obesity, mental illness, social mobility, life expectancy. So a straight index of those against the national income per person, how rich the individuals are within that country. And what you can see is there's no real pattern. It's pretty much a random scattering of countries. What they then did is they took the same index and compared that to the level of inequality in the country. So the gap between the bottom 20% and the top 20% in the country. And what you get then is a much clearer relationship. The lower the inequality gap in the country, the lower the index was of all these social problems. The more unequal the country, higher the index was for all those social problems, health and social problems. And this data the book was 2009. A lot of the data is probably early 2000s. The picture has changed, but it hasn't got any better. But the pattern is still the same. This was questioned. They've repeated the same mapping across the states of America. They've repeated the same mapping across the provinces of China, and the same pattern keeps on repeating. The more unequal a society is, the higher the index of health and social problems. There's something about inequality in itself. And going beyond that, what they also found is in the more unequal countries, the richer people in the more unequal countries did worse than the richer people in the less unequal countries. So it doesn't only affect the more deprived, it affects seems to affect across the whole of the society. There's something about inequality in itself that harms how the society functions in terms of that index, this index of health and social problems. Just adds another bit to the picture about the impact of inequality on health and wider problems. So, a quick summary. People living in areas of deprivation, they don't live as long, spend more of their lives ill or disabled, and there's substantial health inequalities. These are associated with the degree of inequality in the country, and this brings a significant cost to everyone. Yes, social cost, individual cost, community cost, social cost, economic, personal, and cultural. If your population is not as healthy, if your population is not as doesn't have the same choices, then it's going to affect the economic productivity of the country. It's going to have an impact on how economically productive, how effective, how efficient the country is. So there's a much wider impact from inequality and damaging society widely. I mentioned these a couple of times. Marmot review, so Professor Sir Michael Marmot was commissioned by the Labour government to produce a report looking at health inequalities in England. And he produced this report in 2010, Fair Society, Healthy Lives. Then they've just say earlier this year they published an update on that 10 years on to see what had gone wrong. What I would recommend you do, I wouldn't recommend you read the full reports because they are quite substantial. But what I would recommend you do is at least read the executive summaries. As a minimum, the second one, but preferably both, so you can see the pattern as it goes through. If you just read the executive summaries, that really starts to say not only what is going on, it looks at why is it happening, and it also looks at what can be done about it at national, regional and local level, what steps need to be taken to reduce inequality and improve health. And Professor Sir Michael Marmot really, in the first review, really started the discussion around what have been called the wider determinants of health, what he calls the social determinants of health. The conditions in which people are born, grow, work, live and age, and the wider set of forces and systems shaping the conditions of daily life. They include economic policies and systems, development agendas, social norms, social policies and political systems. So the whole of society, political, social, has an impact on the health of a population. And then as part of that, there is also what proportion of a population's health is influenced by the social determinants of health. There's been a number of bits looking at it. This is, and I'm sure, where are we? You will have seen, most of you will have seen the Dahlgren and Whitehead semicircle of health inequalities. You can't produce a public health report without something like that in it somewhere. But this is from Barton and Grant in 2006, Hugh Barton, Marcus Grant, who at the time at University of West England, and they updated it to try and understand it. This is for neighbourhoods. They've done similar mapping for different levels and communities and different areas, and it's middle, age, sex and who you are, how old you are, what your sexual gender is, which is something you can't do a lot about in terms of genetics. Your diet, physical activity, work-life balance, social capital, social networks, community, economy, activities, built environment, natural, global. So it goes out. And as I mentioned before, the focus of an awful lot of public health policy, certainly since probably the late 80s, has been on this one here: lifestyle, physical activity, 5 a day, trying to get people more active, trying to get people to make healthier individual choices, which is very important and a very important part of public health. However, the ability people have to make these choices very much depends on what's going on around them, what job they've got, what housing they got, what opportunities they have in their area. And what if you have a job that doesn't pay you that much, you have poorer quality housing, you live in an area with more environmental hazards, more environmental pollution, you have less access to opportunities like shops, you may have to shop locally. The food environment is less healthy in a lot of these areas. There's a whole range of things that influence your choices. If you're a child growing up in a more affluent household, then you have more opportunities for doing karate, football, going on foreign holidays, going places. If you're in a more deprived neighborhood, those choices may be much more constrained. This isn't about criticizing anybody at any level. It's not about the individuals who are more affluent or the individuals in a more deprived area. It's about the impact of society. It's not about blaming the individuals. blaming somebody for being born rich is exactly the same as blaming somebody for being born poor. It's not about the individuals, it's about the society and the environment and how that affects what choices and opportunities you have. Again, there's a lot of work in trying to understand what the impact of the social determinants are. King's Fund published it in 2014. There's a range of similar pie diagrams in the report, but what they found generally is that the socioeconomic factors account for 50% of population health, genetics 15%. Environmental around 10%, healthcare itself, so of access to good healthcare, access to healthcare if you need it, access to preventative healthcare, at best is up to about 5% of the contribution. By far the biggest contribution is the socioeconomic factors. And again, it's not all about unemployment. This is for you, this is England. This is specifically from England, and it's from the ONS, Households Below National Income. The Child Action Poverty Group, Joseph Foundry Foundation have all published more analysis around this data. But what they found is that 70% of children living in poverty in England have at least one parent in work. So it's not just about unemployment, it's much wider than that. 53% of the children in poverty in England are under 5. More than 2 million children in England under 5 are living in poverty. Poverty defined as an income less than 60% of the median income. So it's less than 60% of the average income in England. So 4.1 million children in the UK living in poverty, which means 30% of children in the UK living below the poverty line. And between 2010 and 2020, child benefit lost a quarter of its value in real terms. So families who have received child benefit, the value of that child benefit has reduced by a quarter in true spending power over that decade. And so this is from the Office of National Statistics. This is again from the Marmot review from 2020, from earlier this year, looking at the average change in council service spending per person by deprivation. So most deprived, most deprived on the left, least deprived on the right. And so the longer the line going down, the more the spending has been cut. So if you look at total local authority spending per person, the grey line, in the most deprived areas, you're talking low 30s, 31, 32%. In the least deprived areas, you're talking about 16, 17%. If you look at adult social care spending, 16, 17% down in most deprived, about 3 or 4% down in the least deprived. Due to the way council spending has been, the formulas for council spending have changed due to the decisions made around how council spending is allocated. The impact at local area has been quite marked, and it's not an equal impact. It is a large impact in areas of more deprivation. What you have to remember there, of course, is that people living in more deprived areas are more likely to need council support services. If you're living in a more, this is a generalisation, but if you're living in a more affluent area, you'll use bin collections, you'll use schools, you'll use roads. You're much less likely to use adult social care funding. You're much less likely to need funding for children's services support. So the demand on council spending in more deprived areas is larger than in more affluent areas. And so this has has a potential substantial impact on the people in those areas and their health inequalities and health. Again, this one here, a lot of information on here, but it's actually quite, if you look, each dotted line is one of the deciles. So they split the population into 10 groups according to the deprivation of the area, where their deprivation. And so the bottom line is education attainment in the most deprived areas, and the dotted line at the top is education attainment in the least deprived area, least deprived areas. So about 51.5, around about 50% here, or about 52% of children in the most deprived areas get five or more GCSEs at grade A to C, whereas it's 68.5% in the least deprived areas. And again, you can see the pattern across the deprivation levels. So again, that's what's happening. The question is, why is it happening? This one's from the original Marmot review, from bottom right here, from the 1970 British cohort study. So they've followed a group of children from birth right the way through and monitored them over a long period of time in what's called a longitudinal study. Q is cognitive score, so intellectual ability. It's not IQ, but it's intellectual ability, the ability of the child in terms of cognition. Two children here, both two with high Q, one from low socioeconomic status, one from high, and similarly two with low Q, one from high socioeconomic status, one from low. What you see is the child with high Q from a high socioeconomic status levels out across there. The child with low Q from low socioeconomic status levels out there. But the child with high Q from low socioeconomic status tends to tail off. The child with low Q from high socio tends to go up, and around about 74 months or so, you get a crossover. So there's something about the environment, there's something about what's going on that means that the more able child from a more deprived area does worse than the less able child from a more affluent area. Again, it doesn't say why, it just says the relationship's there, and it's something we need to understand to know what's going on that's driving this. It's not about the intelligence of the children in these areas, it's something about the environment and the systems around them that mean they don't achieve as well on average. Again, some individuals from all these groups will do better or worse, but on average at a population level, this is the pattern you see. And I think this sums it up. Money just makes things a lot easier. And again, as I must stress, it's not about blaming individual families, individual children at all. It's you're born into where you're born, you grow up where you grow up. It's not about the individuals. It's about how the system and the environment affects people's choices and what's available to them to do better in life, to live long, to have a healthier life, to get a better job. It's not about the individuals, it's about the system and the environment around those individuals that affects them. One way of looking at it are these cycles of injustice. So poverty, deprivation, discrimination, inequality, social injustice, poor physical health, poor social relationships, poor mental health. If you live in poverty, if you live and you have discrimination against you due to ethnicity, religion, whatever, if you experience inequality, you're much more likely to have poor physical health. But if you have poor physical health, you're much more likely to experience discrimination or deprivation. If all that affects mental health. And there's something called the drift into poverty, where somebody may well have a really good job and be doing really well, but then they have an illness, or they get injured, or they have a disability, or have a develop a mental health problem, which means they're not as able to get they can't work, they can't carry on for the same job as long, or they have to work fewer hours, or they have to take a job with a lower demand. Because of that, they have less money, they have to move house. Because of that, there's a whole knock on about access to education. So there's a whole knock on that means that somebody can drift towards poverty, and it's much more difficult to go back the other way. So poor physical health or disability will often lead to social injustice, and social injustice will often lead to poor physical health or disability and poor mental health. So it's those continuing cycles of injustice. And part of the job of public health is to understand what's going on, understand why it's going on, and look at where you can intervene to try and change that. And certainly if you're looking at young people, there's been some good evidence about programs that intervene with young people who are at risk of dropping out of education, young people who are at risk of getting involved in criminal activity, and giving them a structured program to help them move on. Certainly the fire service do work around this, other organisations do work around this, to try and break these cycles of social injustice and health. It's about how do you tackle these problems. I'll leave you with that one. Yeah, it's your perspective can very much depend on your position and your environment and opportunities. There's a lot of these ones from a few years ago, but there's a lot of stuff out there that explain that yes, looks at what's going on, looks at why is it going on, but there's also a lot of this that tells us what we could do to try and put it right. Both Marmot reviews are very, very much part of that, looking really, very robustly at all the evidence. But there's a lot of other more specific stuff. So this is from the World Health Organization. Again, Professor Michael Marmot was involved in that. Better Mental Health for All from the Faculty of Public Health. Again, the Marmot Review team, which is now the Institute for Health Equity, have done work, produced other reports on the impacts of cold homes and field poverty. This one up here, top left, social inequalities are the leading causes of early death. Again, the Institute for Health Equity, the Marmot Review. Marmot, they actually looked at different stages of life, what's contributing towards early death, and is it not sharing? It dropped off. There we are, you should have it back. So this one at the top left here, social inequalities and the leading cause of early death. What they did is they looked at each stage of life from prenatal, baby, toddler, right the way through to old age. What are the factors there that are contributing to people dying earlier than they should? And if you read through that, at old age, some of the things that are affecting people in older age that mean they die earlier than they should is related to what happened to them in the early years as a child. Joseph Rowntree, here we can solve poverty. This was looking at workplace and health. So there's a lot of evidence out there, and from the think tanks I mentioned before, about what we can do to actually tackle the problem. The trick, the science, and especially the art of public health is taking this evidence, taking this information, applying it to your local area and your local context, which you're best able to do. And by context, I mean economic, but certainly the political context. What's already happening in your area that you can use this to help move the discussion and the work on to try and tackle a different area. So it's about taking this evidence and this information and using it in your local area for your local context to influence and negotiate and use the art of public health to try and change what's going on to improve health and reduce the health inequalities in your area and between your area and the rest of the country. Again, as I said, people don't in areas that they don't live as long, spend more of their lives that are disabled. It's the social determinants of health that are the biggest influences. Economy, jobs, education are the biggest influences. The only way you can tackle any of those is by working with local people, but across councils, voluntary community sector, health, police, business, across all those to try and work it together. You can't do that on every single issue. You have to work for the particular topic or area you're working, look at what in my area is important, what does the evidence say, what are the priorities, and then try and work with all the relevant partners to drive that forward. And public health has a central role in this. Yes, in the public health interventions and commissioning, and the commissioning of health visiting and school nursing services is vital for early years. Commissioning of lifestyle services, smoking cessation. There's some of the smoking. I know in some areas smoking cessation funding is under threat. Funding for early years, funding for older people, funding looking at social isolation and loneliness, which has a strong correlation with not only physical and mental health, but early death as well, especially in older people. So looking at social isolation, trying to work out what is it that we need to focus on. So public health interventions and commissioning, yes, but public health budgets are not very big compared to the wider council. It's not about, you can have a big impact in those areas, but it's got to go beyond that. So again, it's about systems leadership, trying to influence across all the wider partners I've mentioned, and trying to build health and well-being into all policy. And again, I would look towards Wales and the Health for Future Generations Act to look at how they're approaching that to try and influence to get a consideration of public health and population health built into all policies. Oh, that's the end of me talking at you. What I'll put at the end here is a list of some of the resources. So there's some stuff on there, epidemiology. That BMJ1, epidemiology for the uninitiated, is a good start if you're interested in the area. The links to some of the data, public health data stuff I've mentioned. The 2 Marmot reviews, and that social inequalities in the leading causes of early death I mentioned. Some of the professional bodies that do stuff that are useful. And I found this one recently. Imperial College have set up some free online courses with an introduction to public health. So I hope that's been useful. It's we've covered an awful lot of areas. We've covered a wide range of topics. Very much an overview, skimming over the surface of a lot of them, but just to try and give a flavour for what public health is and for what the role of public health is, and how it's not just the public health bodies, public health workers, it's everybody else has an important role. So I hope that's been useful, and thank you for listening.